15 years old, went into jail and started self-harming when I was in jail. I had self-harm before when I was younger, but did it in places where it wasn't seen by people. I'd been restrained quite a few times, physically restrained in jail. The restraint's actually a lot different in jail than it is in hospital. Well, nobody likes being restrained. It should always be done as a last resort, because it's not nice being on the receiving end, and I don't imagine it's actually nice to be the person that's actually restraining someone. It's changed in the way that it's used a lot less in a lot more places. People are now more willing to talk to a patient to try and calm them down before it goes into a tertiary level. But it can only be good, because restraining people is quite dangerous. If it can not happen, then that's got to be a good thing. Force is something that people are frightened of. I know I was myself, but any situation for me that went hands-on never turned out well. It always went worse.
We individually risk assess what we do with each service user based on their needs. Our incidents have reduced significantly. In terms of a workforce, you know, on the back of that, our sickness figures have significantly reduced. Staff retention is much better on the PICU.
If I've restrained someone during the shift, I don't feel good when I leave the ward. So, you know, the benefit of being flexible is that there's less restraints, there's less incidents, you know, therefore the patients had a better experience, there's less staff injuries.
When I took over at the PICU, there was high levels of staff going off work with work-related stress, as well as injuries from restraints, and they've significantly reduced.
When you do restrain a patient, the situation actually escalates and there's more chance you'll get hurt than if you know, give them space and have a flexible approach.
We've significantly reduced our sickness levels, our restraints, our use of seclusion, and we had a really positive CQC report recently.
All those years ago it was a mixture of different sorts of restraints, so sort of medical, so medication an awful lot of, and physical restraint, which was dreadful. In the past I've been restrained when I've managed to get out the door, being restrained by two big men, staff. This is a long time ago. And when they got me back in, I was still running, but I wasn't going anywhere because I was restrained with my thumbs up my back. And my feet were still running, but they weren't on the floor, so I was going nowhere. And when people are restrained in that way, it recreates trauma for people that have been abused or been abused in any way. So your legs are parted, and then you have people on your back. And at that time, all I can see is their big hands holding my tiny hands down, and I'm scared. So I won't be able to follow any instructions at that time, because I won't be able to hear them. I can see their mouths moving, but I can't respond. So I will still fight, because at that time I'm not in your world. I'm in a world so far removed that I can't even explain to them. So that's why it's important to find out about someone first. Find out what their history is and why maybe they behave in the way they do. And no force first does exactly that. Makes a difference for people like me and many, many others. No force first is making it better for people like me and will continue to do so.
No Force First is Merseycare's restraint reduction programme that also has the ultimate aspiration of eliminating the use of physical and medication-led restraint on our inpatient units. No Force First, although Merseycare had this aspiration to change things anyway, I think this was really a part of who we were and has been over about the last 3 years or so. No Force First was historically driven to a degree by care scandals. Once that more tolerant environment is generated, we have less physical interventions and less harm for the people we serve, but absolutely critically, less harm for the people who provide care. We can keep staff safer within the workplace, but we can also and we can't ignore this in the current climate, we can make people safer and save money by changing what we do. My take-home message for staff around No Force First, particularly the wards that haven't implemented yet, is this is a fantastically positive process.
So the benefits I've seen for this programme is that it brings the group of staff together to think, how do we help people at a time of crisis so that everybody's kept safe? Well, the No Force First project has been transformational. It's surprised everybody. What started out as a project to reduce restraint led to all sorts of other changes that we hadn't expected. And one of the most significant was that staff sickness reduced on the wards that restraint went down. That not only are patients having a better experience, the number of assaults have gone down, the number of days lost to sickness have plummeted significantly, which was a huge surprise. And that's why I would encourage areas who haven't adopted it yet to learn from colleagues, to talk to people about it, and to see this as the best way to provide care in the future. We can do it in a way that's safe, we can do it in a way that engages people, we can do it in a way that shows it works. It's the right thing to do, it's the safest thing to do, and you have the organisation that supports that. So I encourage people to be open-minded, to learn from experienced colleagues, and to see this as the best way to provide care.
The services that are there now, they're not there to put you down or make you worse. They're there to make you better. It's not going to be easy. There's nothing to be frightened of. If someone's never been into a service before, you would be apprehensive going in because you hear all crazy stories. But no, staff are there to care about you and look after you. And all they want is for you actually to put you on the road to recovery and see you go out and live a normal life again.